Okay. Okay. Moving on with the examination of the strabismus. How do we measure? How do we measure the ocular deviation? That is how much the eyeball has moved. What is the angle of the movement? How do we measure it? We can the first type of test which we do to measure the ocular deviation is the Hirschberg test. Hirschberg test. It is a corneal reflex test. It is a corneal reflex test. We can see the corneal reflex at the center of the pupil and here near the limbus. Okay. It uses the first Purkinje images. We should know that there are four Purkinje images, out of which the fourth one is the real and inverted, and the first three are vertical and erect. Okay, and this test uses the first Purkinje images, which is formed by the interior corneal surface. This uses the first Purkinje image. 1 millimeter decentration of the corneal reflex from the pupil is equal to 7 degree of deviation from the visual axis. Okay, 1 mm decentration of the corneal reflex is equal to 7 degree deviation of the visual axis. So we can roughly classify this as if it is normal, both the corneal reflexes are present in the center of the pupil. If it is 15 degree isotropic, then the corneal reflex is at the edge of the pupil. Okay. If it is 30 degree isotropic, then it lies between the limbus and the pupillary margin. If it is 45 degree isotropic, then it is present at the limbus. Then the corneal reflex is present at the limbus. So 15 degree, 30 degree, 45 degree, 30 prism diopters, 60 prism diopters and 90 prism diopters. Because every degree, 1 degree is equal to 2 prism diopters. Then is the Krimsky or the prism reflex test. The Krimsky test, we do the Hirschberg test. We can see the corneal reflex test present at the limbus, so roughly it will be 45 degree or 90 prism diopters. Next we place the prisms and we see. Next we place the prisms over the fixating eye and we see the corneal reflex coming and then we see the movement of the strabismic eye towards the corneal reflex, and we see at which prism diopters the corneal reflex centers. This is the Krimsky test. Okay. First, we put the prism on the fixating eye and then we keep on increasing the power of the prism, and what is the end point? When the corneal reflex is at the center of the pupil in the strabismic eye. This is the Krimsky or the prism reflex test. In the modified Krimsky test, we put the prism on the non-fixating eye and towards the deviation, and the prism is put and the prism apex of the prism is put towards the deviation. What is Prism Bar cover test? In the Prism Bar cover test, we have the vertical bars and the horizontal bars, and this is and this we can easily slide, and we can easily measure the deviations up to 45 prism diopters. What are the prerequisites for doing the Prism Bar cover test? There should be accurate fixation in one eye. The fixation distance can be both for near and distance. What is the fixation target? For the distance, it is 6/9 Snellen size for accommodative control, and for the near it is 6/6 n/6. And what do we need? We need proper dissociation of the two eyes for doing the Prism Bar cover test. And how do we dissociate the eye? By using an occluder in front of the prisms. Here we can see the prism and an occluder. The occluder is used to dissociate the two eyes, and the prism helps to know the deviation. What is the procedure of doing Prism Bar cover test? The apex of the prism should point towards the direction of the deviation. For example, this is the exotropic eye and the apex of the prism points towards outside. And prism should be increased with alternate cover test. Like we are increasing the prism power, we should also alternate cover test to see any latent strabismus also. What is the end point? End point of the prism bar cover test is no movement of the strabismic eye on alternate cover test. What are the various tests other than measurement of the strabismus which can be used? We can use the test for testing diplopia or fusion. One test is the Wurzburg dot test, in which the red glass is used over the red eye and green glass is used over the left. Remember R for red. So R for red and R for right. So the red glass is placed before the right eye, and we have to see this box, and this box is usually below the Snellen's chart in our OPD. There is a red circle, two green circle, and one white circle, and according to the results, we can label this. If by putting the glasses, the patient can see the red circle, two green circle, and one white circle, then it is normal retinal correspondence. If it is one red circle, two green circle, and one circle which intermittently appears green or red, then it is intermittent alternate eyes fixating. Okay, if it is just the two red circles, then this denotes it is a left eye suppression. If it is a three green circles, then this denotes it is a right eye suppression. If there is a cross diplopia, we will get this thing, in which the red circles move towards the right and the green circles move towards the left. What will be this? This will be uncrossed diplopia. We can also test diplopia using the Maddox rod test. In this, there is a Maddox rod. What is a Maddox rod? This is a lens type frame in which there are cylinders, half cylinders, and if the rods are placed horizontally, then if we are giving a point source of torchlight, and we place this Maddox rod horizontally in front of one eye, what will it appear? The line will appear perpendicularly. A red perpendicular line will appear towards the right eye, towards the eye before which the Maddox rod is placed. If the Maddox rod is placed horizontal, the red line will be vertical, and if the Maddox rod is vertical, the red line will be the horizontal, and from the other eye we will see the point source of light. If there is orthophoria, then this point source of light will lie on the line. If there is exophoria or esophoria, then the point source will shift towards the left or the right. Okay. What is the management? Then we reach towards the management. What are the objectives of the strabismus therapy? We have to reverse the deleterious sensory effects of strabismus, that is amblyopia, suppression, and loss of depth or stereopsis. Stereopsis and depth are different things, but it is beyond the level of the undergraduates to understand, and we have to reverse amblyopia, suppression, and loss of stereopsis, and the best possible alignment of the eyes has to be achieved by either medical, optical, or surgical treatment, and the timing of the treatment in children should be as early as possible in the first year of life, and then later on when the child is above 6 years of age, we can easily do. Medical treatment. Medical treatment, we have to treat amblyopia either by penalization or by occlusion therapy. Occlusion therapy is done in the initial stages, and when the eye starts to reverse amblyopia, we have to maintain that stage by using the atropine therapy, by penalizing the other fixating eye, the preferred eye, with the atropine therapy. We can use the optical devices like the spectacles to correct the refractive error and hence correct the strabismus, or the prisms. Prisms can be used to align the eyes straight forwards. We can also use the botulinum toxin for the temporary correction of strabismus for about 2-3 months, and the orthoptics can be used. Our topics are the exercises. Either using the synaptophore or there are also other exercises. Okay. How do we surgically manage strabismus? This is the last slide. Okay. So, we have to just remember the basic concepts at the UG level. Okay. When we cut the muscle, when we are cutting the muscle tendon and fixing it on the same location, that is resecting the muscle. Okay, that is resecting the muscle. We are cutting the muscle tendon and then pulling the muscle and attaching at the same location. It is known as resection, and because of resection, the muscle always tightens and strengthens. Okay, so whenever we have to strengthen a particular muscle, we have to resect that muscle. What is recession? Recession is we will cut the muscle at its attachment, at its insertion, and then reattach the same muscle tendon at the new insertion, slightly backwards, but yes, before the equator only, not behind the equator, in front of the equator only. So, recession, the muscle mass is same, but the insertion is now slightly lax. That is, it is behind. So the muscle becomes lax. So the muscle is weakening. So whenever we have to weaken a particular muscle, we have to recess that muscle. Okay, this is the basic principle guiding the strabismus surgery. We have to shift the point of muscle attachment in resection and recession, but in recession, we have to shift the point of muscle attachment. In resection, we have to cut the tendon and shift the muscle tendon to the same insertion point. What is a pardon procedure? It is a recession type of procedure, but in this we don't cut the muscle and we don't change the insertion site. We just, whatever the muscle tendon we have, we take a suture and slightly fixate near the equator, the muscle tendon near the equator. We just suture it. We don't cut the tendon. We don't change the original insertion site. We just make a new insertion site over the tendon. And this is a pattern procedure specially used in nystagmus. Specially used for the correction of nystagmus to the primary position. What are the choices of the muscles for surgery? For correcting hypertropia. For example, for correcting hypertropia, we can use either the medial rectus and the lateral rectus. We can we can detach the muscle and reinsert it slightly below the original insertion, or we can do the vertical muscles or the oblique muscles. The basic will remain resection or recession. Whenever there is hypertropia, we have to recess the muscles which pull the eyes upward. Whenever there is hypertropia, we have to recess the muscles. We have to recess the muscles which pull the eye upward and resect the muscles which pull the eye downward. Okay. And now there is a new technique called the adjustable sutures. Adjustable sutures are used for the correction, for the minor corrections of like we correct the strabismus and we put the sutures, and after the post-operative day we still see about 20 degree of correction still remains. So the adjustable suture help to adjust at 20 degree, 30 degree what can remain after the surgery by in the OPD only. So the adjustable sutures can also be helpful. So this is the basics of the strabismus, clinical basics of the strabismus. Rest you can study from the book. And all the doubts are welcome. With this, the strabismus will also be completed. This topic of strabismus will also be completed, and hope to see you during the exam time. Okay.